Well, it really is a privilege to be able to speak to all of you this evening. You know, as all of you are aware, you know, these are unprecedented times in the cancer community and the medical community in general. And I think probably no population is affected more during this time than cancer patients and the elderly with comorbid conditions. And sometimes that's, you know, both communities are intertwined. So what I'd like to do is spend about 30 minutes speaking to you about coronavirus and how it's affecting the cancer community. Start out with a little bit of background information regarding coronavirus itself, and then talk about its specific effects on cancer. And then I'd like to leave a fair amount of time so that we can do a question and answer session at the end. So this that you see on the right here is a picture of a coronavirus or multiple coronavirus particles. And what, you know, is really a myth that needs to be dispelled is that coronavirus is a new infection. In fact, coronavirus has been around for approximately 40 years. As is shown up here, I hope you can see my cursor. About 40 years ago, it was described as one of the viruses that can cause the common cold. So about a third of common colds are actually caused by coronaviruses. These are the strains that are typically identified with the, you know, nuisance common cold that many of us can experience that are secondary to coronavirus. But what has become evident with coronavirus is that it has been able to jump species. So as many of you may be aware, it has jumped from animals to humans and back again. So the animal that's most commonly associated with coronavirus is the bat. So this does have a reservoir in bats, and then starting in the year 2000, after this 40-year history of relatively benign disease, it emerged as the virus that caused SARS. So many of you know that's the Southeast Asian Respiratory Syndrome. And that started in, as its name suggests, in Southeast Asia. It also made it onto the shores of North America, in Toronto in particular. And that was an aggressive, much more severe disease that caused respiratory problems. And the mortality rate of SARS, meaning the percentage of people who died once they contracted SARS, was on the order of about 30%. So it was a very lethal virus, but it was hard to catch. And that's why it lasted for the short amount of time that it did. There was a relatively quiet period for about a decade. And then MERS emerged, which is the Middle Eastern Respiratory Syndrome. And that started in 2012, was, as its name indicates, primarily in the Middle East. And the mortality rate of the MERS virus was around 15%. And again, coronavirus became more commonly known as the common cold until this most current pandemic. So this obviously started in 2019 in the Wuhan province of China. And there's two different names that are associated with it. And you may hear both of them. One is the COVID-19 and the other one is SARS-CoV-2. So those are the names that you'll hear. Now, the reason that coronavirus has the name that it has, coronavirus, is because if you look at this picture, which is an electron microscope picture, corona means crown. So these little extensions off of the viral particles themselves look like crowns, and that's how they're labeled as coronavirus. Did that advance for you? All of you can see that?
Yes.
Good. So this is another image showing a coronavirus. And what this shows that's very important to realize about coronavirus is that the genetic material that causes the problems is in the middle of this virus. And this is what we call a lipid layer or a fatty layer that surrounds the RNA particles in the virus. And then these little spikes, they're called S-glycoproteins. These are what attaches to human cells and allows this genetic material to go into a cell. So these crowns are absolutely critical to the invasion of the genetic material into human cells. Now, another important thing to note is this lipid membrane that surrounds the virus is very much soluble in detergents. So when you hear about what compounds best destroy coronavirus, plain old soap is highly effective. So soap and water is incredibly effective at killing this virus. Other compounds are also effective that many of you I've heard about, bleach and others, and hand sanitizer, but if you don't have those things, soap and water is very effective because it's surrounded by this lipid layer. The other thing that's important to realize is that this virus needs a host to survive. So it can't live on its own for very long. It does live, though, on surfaces. So it has been reported to live for about 24 hours on cardboard, and it lives for about 2 days on hard countertops and stainless steel. So that's why it's important to clean surfaces, because it can survive for a couple of days on hard surfaces. As I mentioned earlier, this virus was found in bats, but then jumped to humans, and that's when this started to be spread from human to human after it crossed over from bats to humans. One myth I will dispel is that this was an engineered virus. There's a lot of evidence that this is not in any way an engineered virus. It is entirely naturally occurring. The final thing I'll say on this slide is the genetic material in the virus is very stable. So that's important because it allows us to develop treatments much more effectively, because the virus isn't mutating. And it also tells us that if we can generate a vaccine, that'll be effective at wiping out this virus. And those vaccines are being tested now, and hopefully will be available within 12 months to 18 months for humans. So coronavirus, and this slide sort of shows some of the facts. It enters typically through viral droplets that we breathe out or sneeze out and linger in the air. And you've probably seen those crazy videos of somebody sneezing and something shooting out, 6, 10, 15 feet sometimes. Those are respiratory droplets. And when those droplets are suspended in the air and an unsuspecting person breathes them in, the viral particles attach with those little spikes to the lining on the inside of the nose, the back of the throat, and the tonsil region. It starts there, and it causes those cells to be overtaken by the virus. They die, and then they shed, and they progressively go further down the respiratory tract. So they start in the nose and mouth. That's why we swab that area. It then progresses down into the throat, and then ultimately into the windpipe and down into the lungs. So the symptoms, as many of you know, is a dry cough, a fever, and shortness of breath. So those are the symptoms that occur when it gets down to the lungs. Early on, when people are infected, though, the symptoms are primarily in the mouth and throat. So sore throat, headaches, muscle aches, and even when people swallow these viral particles, it can cause GI distress and diarrhea. But the main things that you'll be asked is, do you have a dry cough? Do you have a high temperature? And are you having shortness of breath? The other thing I will say is that when the infection gets down into the lungs and is a little bit further along, It explains why sometimes the test can be false negative, because if you're testing somebody's nose and the majority of the infection is in their lungs, there is a rate of false negativity of the test, which is around 20%. Now, this virus is 2.5 times more infectious than the flu. And when somebody becomes ill with this, about 25% of patients end up becoming hospitalized because they're having difficulty breathing and their oxygen levels drop. So 25% of patients become hospitalized if they become infected. About 10% of patients who are hospitalized end up requiring the intensive care unit. And unfortunately, about 2.5% of infected patients can succumb to their disease. That's when you look at all of the over 1 million now patients who've been infected, there is a mortality rate of around 2.5% for this infection. Now, the one thing that is very important to realize is that in Wuhan, where this started, there are 11 million people and 80,000 were infected. So this isn't, as some people have said, a virus that while it is contagious, it doesn't infect everybody. In fact, in Wuhan, only 0.37% of the population was infected with this virus. So it's not as some myths are out there that everybody's going to get it. That's not true. While it is very contagious, the infection rate is quite low. Now, the bad news is that for cancer patients, when they looked at that in Wuhan, the infection rate was twice as high. So when you looked at the number of patients who were infected, who were cancer patients per capita, there was a higher infection rate in cancer patients, and the highest was seen in lung cancer patients because of their predisposition, if you will, already to lung pathologies. The other bit of news, which is troubling for our cancer survivors, is that with infection, the mortality rate or the rate of death in cancer survivors is about 5.6%, which is twice the average of what it is for patients who have not experienced and survived cancer. For those cancer patients who are admitted, remember I talked about a 10% rate of intensive care unit requirements for patients. It's actually 40% in a small study out of China for cancer patients. So almost half of cancer patients end up requiring intensive care unit stay if they are infected with the virus. And probably the most sobering statistic is those patients who are actively under cancer treatment, who have gotten chemotherapy or bone marrow transplant patients and get infected, their fatality rate actually jumps up to nearly 20% in the small studies out of China. Now, it's not universal that would be the fatality rate, but it is pointing to an indication that cancer patients have to be extra careful because their immune systems are affected and they can't quite fight this cancer as effectively. Let me go back to one comment here that I want to make. Part of the reason that patients end up succumbing to this virus is because of the immune system. So if you look at when the virus gets down into the lung and it starts to cause, it starts to kill the lung cells, our immune system attacks the virus and tries to kill it. So what ends up happening is the immune system response to the virus actually brings a lot of immune cells to the lung, and it causes a release of fluid in the lung. So one of the things you'll hear about is what's called ARDS, Adult Respiratory Distress Syndrome. And that's what ends up necessitating a lot of people to go on a ventilator. And I know ventilators have become part of the day-to-day discussions in this. So if patients are able to breathe on their own and fill their lungs, a ventilator isn't needed. But if there's this reaction to try to kill the virus and fluid begins to fill the lung, it's like trying to force air into a full sponge. You really can't do it. And the only way that you can get enough oxygen into the blood is to put a breathing tube in a person and put them on a ventilator and force oxygen into the blood through a wet lung, if you will. And then the next step beyond that is actually to replace a person's lung with what's called extracorporeal membranous oxygenation. So ECMO, some of you may have heard about that. And that's where the patient's blood is actually filtered out to a machine, and the machine oxygenates the blood and gives it back to the patients. So at university hospitals, we've had 2 of our coronavirus patients who've had to go on ECMO because even a ventilator wasn't strong enough for them. And thankfully, both of them were taken off of ECMO, survived, and were discharged from the hospital. But that's kind of the progression. So when you hear about respirators and the need for respirators, that's how that occurs. So how has this changed life for individuals like me and cancer centers around the country? Clearly, we need to be able to still deliver life-saving treatment to our cancer patients. While we want to minimize the risk to cancer patients, it's critically important during this most sensitive and important time in a person's life that they get the life-saving treatment that they need. So in no way, shape, or form will this stop the ability of, whether it be university hospitals or any other cancer center around the country, to deliver the life-saving care that patients need. Now, what we do need to do is deliver it safely and deliver it in a way that doesn't put patients at undue risk. So what you'll see when you go, if you've already been into Seidman Cancer Center or another hospital, is that we've taken a lot of steps in a very short period of time to minimize the risk to patients. We've imposed very strict social distancing guidelines. And now, that's part of our day-to-day vernacular, but that clearly means that we cannot have people congregating in common areas. It's kind of strange. All of our chairs are now minimum of 6 feet apart. And we really try to keep people out of the hospital as much as possible. The other thing that you'll see is every single patient and every single employee who walks into the hospital gets screened daily. Questions are asked and temperatures are taken for every patient that comes to see a doctor and for every doctor who steps into the hospital and every employee. So that happens to minimize the risk. If anybody has a fever or a cough or answers in the affirmative to any of the questions that we ask, we actually separate them from the rest of the population and we work them up to make sure that they don't have this disease. The other thing that we've had to do is really begin to minimize our in-person visits. So, the advent of telehealth has been sped up remarkably. Zoom is a perfect example of it. So we're seeing a lot of patients now virtually. Certainly the patients that need to be seen for physical examinations or who need chemotherapy still come in physically, but we see many patients virtually. In fact, I was just looking at our statistics. We had an increase from about 300 virtual visits per week to about 5,000 virtual visits per week once social distancing was put in place. So that, I think, is going to permanently change healthcare moving forward. The other thing that has been a really difficult thing for us to do is we've implemented very strict visitor policies to the hospital and to our infusion and ambulatory facilities. Because of the vulnerable nature of cancer patients, we actually allow no visitors to come with a patient to get chemotherapy or to see their doctors. The reason for that is it's simple. Healthcare facilities are bustling places. On a typical day on our ambulatory unit and Seidman Cancer Center, we'll see 200 patients in the clinic and another 100 patients in the infusion area. If they all bring guests, instead of having 300 patients on the pavilion, we'll have 900 patients on the pavilion. And the risk of spreading the virus to patients and to healthcare workers is extremely high. In New York and in Detroit, where I'm from, 30% of healthcare workers are positive for coronavirus. So they are as much of a risk to our patients as the patients are to the healthcare workers. So we've instituted a policy of masking for the patients and our healthcare givers to minimize the risk of infection back and forth. We are isolating all COVID positive patients. We're continuing to treat them if it's absolutely necessary. But for those where treatment can be delayed until they recover, we prefer to stop the treatment, suspend it, wait an appropriate period of time, which is usually 2 weeks until there's recovery, and then reinstitute the treatment after they've recovered from their coronavirus infection. The other thing that we've done is for our patients who test positive, we suspend their treatment. And if they're not ill enough to be admitted to the hospital, we monitor them at home. So we've created a platform which looks like an Apple Watch that somebody will wear, and it puts a little probe on the end of their finger, and it measures respiratory rate, temperature, and oxygen levels in the blood. And it is monitored remotely by nurses 24 hours a day in the hospital. And if we see that anybody's oxygen levels dropping, their temperature's going up, or their respiratory rates going up, we call them and make sure we get them into the hospital as soon as possible. So that's active surveillance that we're doing for patients to try to minimize their risks. And then finally, when patients are virus-free, we begin therapy for them and get them back on their road to recovery from cancer. The last thing I will say is, what can you expect to see the next time you come into Seidman Cancer Center, your oncologist's office? It'll look very different if you haven't been there. There is first of all, everybody will be masked. You'll walk into an area where in many, there's only one entrance to all of our facilities, and that's essentially on purpose because everybody who walks in will be screened. There'll be somebody with a mask who's going to ask you questions about fever, shortness of breath, diarrhea, travel, cough. And if you answer affirmatively to 2 of those questions, you are actually going to be put into a different area and evaluated for coronavirus. But that is, sort of the first thing that'll greet you. Doesn't seem very friendly like our usual greeters do, but it's a necessary step. The other thing you'll see as you go to check in is there are a lot of plastic shields that have been put up between our registration individuals and the patient. One of our screeners and registration people actually converted positive to coronavirus at Seidman Cancer Center prior to this being instituted. Fortunately, she's doing very well. But just like you see at the grocery stores, those plexiglass windows, those will be up at the registration desks. And then when you get to your appointment, you'll see that the providers are masked as well. But all that is done for your safety and for the safety of healthcare workers. Fortunately, what I can tell you is our governor and our states and Dr. Amy Acton, who I knew when I was at Ohio State, all of their implementation plans and social distancing, which was well ahead of the curve, has really protected Ohio to a significant degree. You know, when you look at the availability of ICUs and beds throughout the state, we are actually at this point in very, very good shape with plenty of capacity and lower numbers than what were projected. So that is the positive news that I can share with all of you. You know, the peak for Ohio has been pushed back. It's expected to be at the end of April and early May. But so far, what I can tell you is we've had, you know, very manageable numbers of patients. When you look at Ohio, as of today, there were about 4,000 plus patients who were diagnosed with coronavirus infection. About 1,000 of them were admitted to the hospital. And about 156 or so were in ICU scattered throughout the state. So those are the, you know, the most recent numbers. What I'd like to do is now leave it open for questions. I'm going to stop sharing my screen, and I'm happy to take questions and see if there have been some submitted from the chat feature.
So Dr. Teknos, thank you so very much. We do have a few questions that people have submitted, and if you still have other questions, you can go to the chat and submit your question there, and then we will share it with Dr. Teknos. So this is really kind of a two-part question, Dr. Teknos. Are all cancer patients at high risk for getting COVID-19, or just those who are currently in treatment because their immune systems are compromised?
That's a great question. I think when you look at the data, when you look at the data, it appears that the infection rate in cancer patients is about twice as high as the norm, you know, the standard population, and that may be because cancer patients, by definition, when you're a survivor, your immune system has been altered, and you are relatively immunocompromised compared to other individuals. So cancer patients are at a bit of a higher risk with regards to the data that's available today. And it looks like the risk is twice as high as the general population. And as I'm sorry, and Chris, not to interrupt, and as I mentioned, it also appears that lung cancer patients, for whatever reason, tend to be even at higher risk.
Thank you, Dr. Teknos. So this kind of ties into that first question with regards to with regards to the immune system. If a person has completed treatment, say 10 to 12 years ago, is their immune system still as compromised?
I think, you know, the answer to that is a cancer patient's immune system is most compromised during treatment. You know, the white blood cell counts, and, you know, and certainly all cancer therapies, chemotherapies, radiation, and certainly transplantation results in significant immunosuppression. But there is persistent relative immunosuppression even 10, 20 years after someone is successfully treated for cancer. So cancer patients are always relatively immunosuppressed compared to the rest of the population. That's also what occurs with people who have comorbid conditions. So heart disease, diabetes, COPD, those patients' susceptibility to infections, particularly respiratory infections, are higher, similar to cancer patients. So when you look, cancer patients are more susceptible, and their immune system is permanently altered from their therapy.
Thank you, Dr. Teknos. Another person wants to know if you could please speak to the difference between droplet and airborne spread of COVID-19.
Sure. I think probably the easiest way to think of it is they're really similar, one and the same. So think about if you were to sneeze, or just think about blowing bubbles, you know, with the kids in the backyard. You know, imagine that action, you create a bubble, but that's exactly what happens when we exhale. When we talk, we are exhaling minuscule, tiny little droplets of water with virus or bacteria in it. And that's hard to conceptualize, but that is what happens whenever we talk. The other thing is when you sneeze, those droplets then, or cough, those droplets are actually forcefully expelled. So just imagine those bubbles being microscopic and having virus, and then the bubble, as one person breathes it out, the other one breathes it in. So that is the droplet, and that's how the virus gets transmitted from person to person. The other way is on our hands. So that's why touching our hands to our face or to our eye after touching a contaminated doorknob or cabinet, or shaking somebody's hand who sneezed into it, is another way you can introduce it to your mucous membranes. So they're really one and the same, droplet and airborne.
Thank you, Dr. Teknos. And this question is kind of piggybacking off of that with regards to airborne and droplets, because we've been hearing a lot about the importance of going outside, and that's one thing that we can do while still practicing social distancing. But if you're out walking and someone is in the oncoming vicinity and they cough, how long do those particles linger in the air?
That's a good question. So the thing and I want to take a step back just to kind of answer that question more globally. There are a lot of studies that have come out that talk about the length of exposure that's needed for an effective transmission of the virus. So what's considered an intimate exposure to somebody is being within 6 feet for 15 minutes. And that, so healthcare workers in Singapore, for instance, when they wore a mask, not even a N95 respirator mask that we're talking about, but just a regular old mask that is only about 50% protective, and were with a positive patient and spent no more than 15 minutes with that patient, no healthcare worker got infected with COVID. So you need a high volume of the virus and an extended exposure to the virus to catch it. So by having somebody just run by you, because I did this the other day, I was out for a run and I ran by a lady and she started yelling at me because I was too close to her. So I experienced it myself. I didn't have time to explain the length of exposure in viral particles, but you need an extended exposure to a positive patient with high viral load to catch it. So if somebody just breathes in your direction, it's very unlikely that that's going to put you at risk.
That was very helpful and informative, and I'm sure a lot of people appreciated hearing that because people are spending a lot more time outside. You spoke a little bit, Dr. Teknos, about limiting access to loved ones in the hospital, and one of the questions speaks specifically to what are you doing about a significant other coming to the hospital during someone's cancer surgery?
Yes, that's a great question. So, while this policy is really trying to protect patients and healthcare workers, clearly there have to be exceptions that are made. So one exception is there is one visitor allowed on the day of surgery so that they can be with their loved one, prior to surgery and see them after surgery. So that is an allowance. The other allowance is at end of life. So unfortunately, when patients, and you've heard the stories, which are heartbreaking, of patients who are dying of COVID who are not allowed to have visitors. I think for our cancer patients, if they are not COVID positive, we do allow visitor at end of life. So there are exceptions, and we do make exceptions, in unique situations. But day of surgery, we do allow one visitor to come in.
Okay, thank you. The next question, will the therapeutics that might be coming available and potentially helpful for cancer patients, will they be, oh, wait a minute. I'm sorry. I'm trying to make sure I read
Will they
this
be as available? Yeah, and potentially helpful for cancer patients.
Thank
So,
you.
So I think there are, as you can imagine, there are a number of therapeutics that are being tested at present. I can tell you, as a cancer center director, I probably get 40 emails a day about some, novel treatment that they want to introduce to patients. So we have a very rigorous scientific group that vets every possible therapeutic, and we have a number of clinical trials now that are offered to our patients who have cancer and are COVID positive. So the therapeutics will be made available, and in fact, some are exclusively for cancer patients. One in particular is a drug that is out of Takeda, one of the pharmaceutical companies that we were using for solid tumor cancers, but it also has antiviral effects. So now we've expanded it to be given to COVID positive cancer patients because it has both anti-cancer and antiviral effects. The other one that you've heard about is this drug from Gilead Pharmaceuticals. So that's called remdesivir. That has been shown to be highly effective against this virus as well as Ebola, actually. So we were the first hospital in the country at university hospitals to open this trial, and we're actively treating patients who are moderately ill, admitted to the hospital and have pneumonias, and those who are severely ill in the ICUs with this compound. So all those therapeutics are being made available to cancer patients. And then finally, I'm sure there's going to be a lot of questions about hydroxychloroquine and azithromycin. And the fact is that there are trials, that are ongoing with hydroxychloroquine and azithromycin. There's a randomized study that was just published out of China, which had 31 patients taking hydroxychloroquine and 31 not taking it who were admitted to the hospital. And the time to treat, the time to essentially reverse a patient to normal was shorter in the hydroxychloroquine group than it was in the supportive care group. So there is some evidence that's coming out that's randomized and that's more scientific that may support that, but it's not something that we can use prophylactically by any stretch of the imagination. And there are certainly side effects to it, but it's promising, and I think all of these trials will be taking place throughout Northeast Ohio and beyond.
And since we're talking about medications, I'm going to share this question, and it's around immunosuppressants. And this person is asking, should they be stopped if you're taking them every day, and is that also considered in treatment?
Well, I guess the question is, if you need your immunosuppressants for your health, they shouldn't be stopped. So, for instance, folks who have transplants, who've undergone organ transplants and need their immunosuppression, it's very important to continue those medications. Folks who are having immunosuppressants for Crohn's disease and ulcerative colitis, those are necessary immunosuppressive agents for individuals to continue. But if you're on a immunosuppressive chemotherapy regimen that can be stopped and not affect your health, then those should be considered as something being stopped. For instance, in our cancer community, a lot of breast cancer patients are receiving Zometa for the treatment of their bony metastases. that is something that can be stopped during this period so that patients don't have to come in and run the risk. So the answer would be, I would only stop a medication if it's safe to be stopped for a period of a couple of weeks, and you definitely need to consult with your physician on why you're on that medication. I will point out one interesting fact, and that is that solid organ transplant patients, so heart transplants, liver transplants, who are on immunosuppressive agents, remember I told you that our immune system sometimes, the reaction of the immune system is what causes the severe respiratory problems that we have because it fills our lungs with fluid. Patients who've had solid organ transplants and are on immunosuppressives actually do not show worse outcomes with COVID virus. And the belief is that the depressed immune function keeps the lungs from filling up with fluid. So it's a decision that has to be made on immunosuppressives on a case-by-case basis with your doctor.
Okay, thank you, Dr. Teknos. So there are a couple of questions that are pretty similar with regards to, I'll read the one question, and then the other really speaks to what will happen for cancer patients after this COVID-19 virus is hopefully done. And so the one question starts off, it doesn't seem that there will be enough infections for the population to develop herd immunity. So without a vaccine, will cancer patients ever be able to move around the world safely? And then the other one just speaks to what can cancer patients expect as this COVID-19 comes to an end?
Yeah, those are great questions and very thoughtful questions because, herd immunity, just to kind of level set that, if 80% of a population is immune to a disease, that's enough to sort of put a virus out of commission. That's what herd immunity is. That also means if you vaccinate 80% of the population against a virus, that virus will cease to be relevant, if you will. That's why for HPV vaccines, if we could get up to 80% and develop herd immunity, then cervical cancers and head and neck cancers would cease to be as big of a problem. So it's a very, very smart question. As you saw, only less than 1% of patients right now have tested positive. So as Dr. Fauci said, this virus is going to change the way we live, unfortunately, until a vaccine can be developed or an effective treatment can come into play. So I think, I think our social distancing is going to relax when we can do a blood test and see who's had the virus and who has immunity. And those people can certainly freely move about the world and about their communities. But I do think that, and I always used to question, why did the Chinese always wear masks and the Japanese? And from the United States, we always would question that. And I think it's because they've lived through these pandemics, through SARS and, Asian flu and whatnot. I think our world's going to be very different. And I do think that it's going to be a challenge to return to normal without these social distancing guidelines and concerns until we have a vaccine.
Okay. Does the use of a Cpap machine increase the infection rate or risk?
Another good question. So it does not increase your risk. Certainly, just like with any Cpap machine, you have to clean it on a regular basis, but it's not a mechanism. That is not a mechanism to introduce COVID virus to a patient. It's really droplet contamination of your airways. So unless somebody with COVID coughs into your Cpap machine, it's unlikely that that's going to cause you to have coronavirus. Now, One thing that I will say is, and for those who use CPAP machines, as you know, CPAP delivers oxygen, or it delivers air under pressure. And there are many studies going on to actually convert CPAP machines to respirators in the event of a respirator shortage. So if anything, those could be lifesavers down the road.
Is it possible for a current cancer patient, someone who's receiving treatment, to be exposed to the coronavirus and not become ill?
Absolutely. So in fact, we have seen that in our own patient population. So, there is a belief that about 50% of patients who are infected with coronavirus display no symptoms at all. And, we have instituted a policy at university hospitals where before anybody has a cancer surgery, they are going to be tested for COVID. And we've had completely asymptomatic patients test positive. So cancer patients, just like the rest of the population, and that's what makes this virus very unusual, can have the virus with having not a symptom that is recognizable, which is a problem, certainly, because then those folks can spread the virus to family members and to friends if they're not socially distancing.
So Dr. Teknos, you've talked a little bit about lung cancer survivors or individuals who've been diagnosed with lung cancer and an increased risk. So are there some additional precautions that a lung cancer survivor should be taking during this time?
I think no more than the rest of us are taking. I think, certainly, following all of these guidelines that are out there, masking, if you're out in public, until the virus is under control, is what all of us should do. I think the data that I report is just that they're at a little bit higher risk of getting the virus and of getting sick from the virus. But I think their method of prevention is just like any of us would be following. And that's just good hand washing and appropriate social distancing.
Okay. So you bring up social distancing or physical distancing, and one of our viewers is asking, how would you have a social distance with family members within the home if they are working outside the home and that family member is currently receiving treatment?
So if the family member is a cancer patient, you mean?
Correct. If there's a family member that's receiving cancer treatment and they have family members in the home that are going outside to work.
Yeah. So I think
we need to think about.
Yeah, I think that's that's a very important question because certainly you want to minimize the risk to your loved one who's a cancer patient. So what happens with healthcare workers is they tend to do the following. So when you're at a high risk environment in the healthcare arena, what many of us, sorry, my, can you still hear me?
We can.
Oh, you probably can't see me though, because my computer just went to sleep.
We see you.
Oh, you do? Okay.
We do.
Okay, good. I'm back. Now I can see. So a lot of healthcare workers, what they've done is they will take their shoes and take their clothes off at the door, shower, and before they greet their loved ones, just to minimize the risk of bringing, any droplets and any risk of infection into the family. And then, follow typical, social distancing parameters once you're in the house. But I think, making sure you don't bring, the virus in. And then certainly if you develop any symptoms, cough, runny nose, masking is critically important.
Okay, thank you. Can you speak about expanding tests to non-symptomatic people? Do you think that's something that's coming to the public soon?
That is, certainly the prayer and the hope. So right now, the tests still are limited in their numbers and in their availability. So not in the sense that we can't do them, but we're doing them primarily on people we're suspecting have the virus. With the further progression and the further advancement in testing, I think the key is going to be not only testing asymptomatic people to see if they have it, but more importantly, testing the patients for antibodies that they had it and now have recovered. And in South Korea, the reason that they've been able to open up their communities is they both can test asymptomatic patients to see if they're carriers, but more importantly, they're able to test nearly everybody to see if they were exposed and recovered. So I think the key is going to be that antibody test where we're going to be able to check individuals and say, you know what, you didn't know it, but you were exposed and you now are immune to this coronavirus strain. And then those who are asymptomatic, to be able to test them. And we're, and to qualify that, we've actually begun doing that already in the cancer program. So individuals who are going to have surgery and are going to need to be admitted to the hospital for cancer surgery, or individuals who are going to have bone marrow transplants or start of new intensive chemotherapy are going to be tested even if they're asymptomatic.
Thank you, Dr. Teknos. We have a few questions that I'm noticing that are very specific to an individual as opposed to more general questions. So I'm going to pose a couple of them, and you may you may say that they might need to follow up specifically with their doctor.
Yeah.
But I am going to pose this one specifically. I am just finishing up radiation this week, which followed surgery for lung cancer and chemotherapy. I'm considering immunotherapy to begin in 4 weeks. The infusions are every other week for a year. I'm hesitant to start this if the virus is still ongoing. The treatment be delayed.
So that is a great question. I believe that, it's probably best handled, as you said, with a discussion with their oncologist. And what we've done, at university hospitals, and I think a lot of programs have done, is if it is deemed that a treatment can be delayed without affecting a person's ability to be cured from their cancer, we are delaying it. So we've gone through every single disease, every single indication, and said, this is a priority C indication, meaning, not a high priority, and all those chemotherapies are being delayed. So you can tell that patient that there will be guidance from their oncologist that's very specific for them. And it should only be delayed if it's not going to affect their overall ability to beat their cancer.
Thank you, Dr. Teknos. Another question, if a person who's either in treatment or a survivor, if they believe that they're experiencing symptoms, the COVID-19 symptoms, should they reach out to their oncologist or their family physician?
That's a great question. I think I would let your oncologist know, because I think oncologists are acutely aware of the unique risks that a cancer survivor has to this virus. And we also have better access to testing because we can test within the cancer centers much easier than potentially some of our primary care colleagues. So I would advise them to reach out to their oncologist and inform them of the symptoms, and they're more likely to be tested in a timely manner that way.
Thank you.
In fact, the Seidman Cancer Center, we've set up a COVID rule-out clinic. So for our cancer patients, anybody from anywhere across the community, if they're suspicious that they have the symptoms, we've created a special area where it's separate from the main population, and we do chest x-rays, blood work, give fluid if we need to, and test patients right there, so they don't have to go to the emergency department, which is obviously a very precarious area to be in this day and age. So we try to keep our cancer patients out of the EDs through this special clinic.
So Dr. Teknos, another question. There are so many videos on making your own non-medical masks to use when moving around in public. Would you recommend this?
Yes. So, there is guidance from the CDC that when we're out in public, we should wear masks, and what we've learned, and I'll give you some statistics that back it up. So those N95 masks, those respirator masks, those are, as the name implies, 95% or greater at filtering out droplets, no matter how small, that could have virus in it. So they're 95+% protective. Surgical masks, and as you know, those can be a little loose inside. Those are about 70% effective at limiting and preventing the spread. And cloth masks are 50% effective. So they are actually not too far off from surgical masks, medical grade surgical masks. And the other reason to wear them is even if you're asymptomatic and you go out in public, you're not going to be, and it's really to protect others as much as it is to protect yourself. If you happen to cough, sneeze, or breathe in somebody else's direction, it's not going to generate, the plume, if you will, of droplets. There'll be a physical barrier there. So I would recommend wearing those until we're sure that this pandemic period has passed.
Thank you, Dr.
Easy to do. My daughters showed me the bandana one with the coffee filter, and it takes about a minute to make. In fact, the CDC, if you go, on the CDC, there is on their website 3 different potential ways to make cloth masks, and one of them includes the bandana with the coffee filter in it.
Perfect. Thank you so much. Another question. Once you've been exposed to COVID-19 and recover, are you then immune to it?
Yes. I think the good news, as I mentioned during the, sort of the lecture part of the talk, was that this virus doesn't mutate very much. So the reason we keep getting flu shots every year, there's hundreds of strains of the flu. Every year, epidemiologists try to figure out which of the flu strains is likely to be the one that's going to cause people problems. So and that's because the flu mutates a lot. This virus to date has not mutated very much. So if we can develop a vaccine, it'll work great. But then it also means, that once you've developed an immunity to it, you're good to go for that strain of the virus forever. That's the beauty of our immune system. It has memory cells, and it just kicks in whenever it sees it again and kills it. One thing just another comment I'll make on that, there's been very little that's been seen in the way of mutation of this virus. I've mentioned that. But the one mutation that's been identified was in Singapore. And I won't go into too much detail, but it involved those spikes that we talked about. And the mutation that was seen in Singapore actually made the virus less infectious and less deadly. So that's good news. And certainly if there's no clear evidence to date if that virus has made it to the United States, but it is a less deadly form. And definitely the mutations are not getting worse. At least that's, they're getting, the one that's out there is better. So let's hope it doesn't mutate. But to get back to your question, if you've had it and you're immune forever to this strain.
So let's expand on that a little bit more, Dr. Teknos. The question is, do you have immunity even if you had a mild response to COVID-19? Does that matter?
Yes, you have immunity even if you have had a mild response or no response. And really, nobody knows why the responsiveness is so different and why some people are asymptomatic. But even if you haven't had symptoms, you've developed immunity to it. And, so you will be protected forever with these memory cells that our immune system creates, and can recognize this virus in the future if you're ever exposed again.
Great. So you were talking a little bit about masks a few moments ago, and one of our listeners is asking, once you use a mask, can it be reused? And if so, how often?
That's another great question. So, the recommendation for cloth masks is that you can use them for as long as you'd like. The recommendation is to launder them daily. So at the end of the day, wash them, and then you can re-wear them. Isolation masks or surgical grade masks, we're actually doing this in the hospital, is we're reusing them as long as they're not soiled. So if you don't, if they're not soiled, you haven't been in contact with somebody who you are very concerned could have had the virus, then you can reuse them until the mask is no longer functional. So they are reusable. And the cloth masks, as I said, the recommendation is to launder them just with detergent daily.
Excellent information. Someone would like to know if cancer patients should be taking probiotics to help with their immune system.
That's a great question. There's so much about the microbiome, our gut microbiome, that we don't understand. So I think it can't hurt. Let's put it that way. I think a healthy gut does promote a healthy immune system. So there's certainly no reason not to take probiotics.
Okay. And I think you might have alluded to this a little bit earlier, but I'm going to ask this last question that I see in our list. Are there any over-the-counter meds that you can take to help avoiding catching the COVID-19?
Unfortunately not. There used to be. So there was a compound. Well, there was a compound that is actually manufactured here in Cleveland, and there was a mouth spray called Halo that was on the store shelves up until about 2 weeks ago. And that compound was shown to be protective against flu and cold viruses, but really wasn't a top-selling over-the-counter medication, if you will. But once all of this started to occur with the pandemic, the company pulled all those off the shelves and are now doing clinical trials in healthcare workers. So we actually are launching that clinical trial for our caregivers at university hospitals. The Cleveland Foundation has funded a trial to the tune of $1 million to investigate if this can prevent COVID infection to healthcare workers who are at the highest risk. And if it works, then certainly that's going to be something that will be widely available and hopefully within a short order. But nothing else over the counter seems to be particularly effective.
Well, thanks for that information. So I'm glad the listener asked that question.
Yeah, and let's, it's interesting just to expound on that study a little bit. The research was done at UH by Dr. Salata, who's our chief of infectious disease and Department of Medicine. And they gave it randomly to medical students during cold and flu season. And there was about a 30% decrease in cold and flu in those that took this spray. So it didn't eliminate the risk altogether, but it did seem to be protective. So stay tuned for those studies that hopefully will come out soon.
Okay. And our final question, you had mentioned lung cancer patients sometimes doing better due to the immune system not making the virus worse. Would the same hold true for chemo, for patients in chemo that have low counts?
No, unfortunately, what I had said is that patients who, by the way, notice I touched my nose. I'm washing my hands right after. Are going to notice that. Just like whenever there's like a press conference, people bring it up. But so I promise you I'll wash my hands right afterward. But so what I talked about was lung transplant patients and organ transplant patients who are on immunosuppressants. Because of the particular type of immunosuppressant that they take, it decreases a certain part of the immune system that has been shown not to negatively impact transplant patients, solid organ transplant patients with COVID virus. Unfortunately, for cancer patients, it's a universal immunosuppression, so the virus actually progresses much more rapidly in immunosuppressed patients who are on chemotherapy. So being immunosuppressed and having cancer is not protective at all. In fact, it increases the risk of problems.
Okay. Dr. Teknos, you have been just doing a fabulous job of answering these questions in a way that's very understandable. So our final question, what can we do, the community, to help healthcare workers?
That's a wonderful question. And I think, the community, if there's one silver lining in all of this has just been seeing the community support that is out there and the love that's been shown to our fellow citizens and to healthcare workers. So that is really important. Believe it or not, we are in desperate need for masks, believe it or not, and face shields. So I'll put this in perspective for you. We were supposed to receive a huge shipment of surgical masks from China, and they never made it off the docks in China. There's a lot of issues. So we are actually running short in a lot of hospitals of surgical masks. So the cloth masks that people make are incredibly helpful at this point, because we would like, and what would be the ideal would be to have every healthcare provider and every patient have a mask, and that would decrease the risk of infection. But we don't have enough to supply that. Basically showed us an analysis that we would need 200,000 masks a week to be able to just mask our healthcare workers, not to even mask our patients. And, so we would be burning through, nearly 2 million masks, in a period of 10 weeks. And, there's not that many masks out there, believe it or not. So we would love the support of individuals if they want to make masks, face shields. There's been some companies that have stepped up and are 3D printing face shields as well to protect healthcare workers. And then just, reach out to your friends who are healthcare workers and thank them. There are a lot of people struggling in the healthcare field because, we know what we're getting into in healthcare. But as somebody put it, we know what we're getting into, but our families, are put at a lot of risk. So supporting those who are doing the work day to day is critically important. And just shout out and thank your friends who are healthcare workers, because they're struggling.
Yes, and thank you, Dr. Teknos. I do see one other question that has come through, and the question is, if you're going to have surgery, should you bring your own mask for the period you will be in the hospital?
You know, that's a great question. I would bring one just in case.
Okay.
How about that? Because, you know, our inventory ebbs and flows every day. In fact, just to give you a perspective on this, every single mask in the hospital has to be signed out and has to be accounted for just because of where we are with regards to shortages in inventory. So I would bring it just in case, and certainly if we have surgical grade masks, we'll give them to patients. But I'm advising patients, and I sent out an email today to all our schedulers telling them if they're coming for an ambulatory visit, they should wear a mask, even if it's a cloth mask. And I would certainly advise those coming in for surgery, if they have a mask, bring it with you. And if we can supply it for you, you can use it for when you go home.
Wonderful. So Dr. Teknos, I do see a note here for mask making information. So if there's anyone on this call today who is interested in helping to make masks for healthcare workers, you can go to Cleveland volunteer at uhhospitals.org. Again, that's Cleveland volunteer at uhhospitals.org.
Can you even believe we're talking about this? That's
No.
the amazing thing, you know?
Yeah. And then finally, someone said, this has been very informative, Dr. Teknos. We're very glad we tuned into this talk. Thank you so much for your time. And with that, I'm going to turn it back over to our CEO, Michelle Seranian, so that she can have final comments. Dr. Teknos, thank you.
Thanks for the opportunity. I was honored to do it.
Well, Dr. Teknos, thank you. I can't thank you enough. I know I learned an awful lot listening to you tonight, just as I know others who were on the call have as well. I know how busy you are and how dedicated you are to your patients, so thank you for taking the time to do this tonight. I also want to thank everyone who's been on the call. I also want to give a big thank you to our donors, who it's through their support that the Gathering Place is able to make programs like this to cancer patients free of charge. So thank you again to our donors. Our next town hall will be Thursday, April 16th at 6:30. Robert Valente, a retired financial planner who has been a volunteer with the Gathering Place for a number of years, is going to be talking and providing insights on the topic finances in COVID-19. There are so many challenges that we're all facing today, but cancer patients even more in terms as they worry about treatments and costs and so forth. And he'll be able to answer questions about the new stimulus package and other questions you should be asking of your employers, healthcare partners, and so forth. This program is being provided by the Gathering Place to help those that are coping with cancer. We want you to know that our staff is available to you. Even though our doors are physically closed to you right now, we are available by phone. We are available on our website, which is all kinds of resources for you. If there are newly diagnosed cancer patients, please know we still are here to help you. Just call the Gathering Place and someone from our team will call you back and talk with you. Thank you again for everything this evening. Our website, touchedbycancer.org, is available to anyone with all kinds of resources. We have recorded the conversation this evening, and we will be putting that up on the site also. Thank you so much, and God bless all of you, and stay well. Thank you.
Thanks very much.
Thank you.